Can I call the members of the panel discussion? So this was kind of a preamble for a panel discussion. We're going to do it a little differently this year compared to what we've done before. And Harish, James, and so what we're going to do is we're going to have a few. So we've got about 45 minutes in this session. We stuck to time, which is good. We have about 5-minute presentations. Apologies from Shabir Madhi, who was going to be here from South Africa, but the flights were really quite onerous. He had a 30-hour flight to come via Brazil. He had to stay overnight in Brazil to come here. They canceled all the South African flights to Argentina, unfortunately. So Shabir sends his apologies, but he sent 3 slides, which I will present. Some of the data and to answer some of the questions that were raised about co-infections and mortality and really how that occurs. So I'll start with, so we'll each make short presentations with time for a question or two. The longest is Fernando, but he promises me he'll be able to do it quickly. And let me introduce to you the members of the panel. You all know Fernando in the center. Harish Nair is from the University of Edinburgh. He's done a lot of the global burden of disease studies, which I'm sure everyone has quoted. And James Noakes is from Kenya, where he's worked for the last 19 years or 18 years? 15 years. A long time, and everyone knows James' work in Kenya on RSV. So I'll start briefly to give you an overview of where we are at, and then we'll move forward. And so I just to reiterate, because I understand there are people who are not lab-oriented, but this is the burden of disease studies, and quite a few of the people who did the studies are here. Kate is here, Kim Mulholland, who did the HIB studies, and of course Harish. And these are 3 studies or 4 studies that look at the burden of disease of potentially the 4 most important causes of pneumonia in children. And they were all published some time ago. Harish is going to give you an update on these estimates for RSV. So clearly RSV is the single most important cause of hospitalization, as Kate showed you, and we're all aware it was estimated to cause about 33 million hospitalizations a year. Influenza was second, at least the estimates that we had, pneumococcus and Haemophilus. On the other hand, the case fatality rate, the mortality from pneumococcus is the highest, Haemophilus influenza second, RSV and influenza. So if you put this into context of the 156 million acute lower respiratory tract infections that occur, what proportion of those really have a potential cause ascribed? And at least as was published in those series of articles, 22%, so 33 million of 156 million, 22% are caused by RSV, 13% by influenza, and 9% by pneumococcus. But the vast majority at this stage, that was a few years ago, really still remain unaccounted for in this pie. What proportion of these have a potential cause ascribed? A much larger proportion of the children who die have a cause ascribed, and only about 26% of them was it equivocal at the time of publication some time ago. But pneumococcus clearly has the highest burden of disease. So just a preamble, we now have new estimates of RSV global burden of disease that Harish will present. James will present some data on morbidity and mortality from rural Africa with low comorbidity. As you saw, the underlying theme above was comorbidity seems to contribute to mortality quite a lot. And we'll hear from James about his experience in Kenya, where there's low comorbidity as a factor. Then you'll hear from, Shabir, actually, I'll give Shabir's talk after Fernando. He has just a few slides, and I'll talk on his behalf. And he has a high rate of comorbidity in Soweto. And Fernando will talk about comorbidity and at least mortality as relates to his studies in Buenos Aires and outside. So with that, we'll start with the first first talk for 5 minutes, and there may be a time for questions.
So thank you, Eric, and hello, everyone. I'm very glad to be here in this wonderful city. So due to paucity of time, I'm going to just focus on RSV mortality in infants. And Eric's already mentioned about the previous estimates, and most of you are aware of these. So we had published that between 53,000 to 199,000 deaths could be due to RSV-associated ALRI. And we did not have enough data for a point estimate, so we gave a boundary. And the lower boundary was for in-hospital deaths. That was based on 12 studies. And the upper boundary that included the out-of-hospital mortality was based on data from a single site from a study in Lombok. And these estimates which we gave were for overall for under 5 children. We had no estimates for infants. So we were given a grant by the Grace Foundation, and we've been working on this for the last 3 years to come up with updated burden estimates for 2015. So as part of this, we updated the systematic review. And what you may want to focus on here is that we now have substantial data on in-hospital mortality. That was what Eric was alluding to earlier. We have 98 studies that report in-hospital case fatality ratio. And that includes 77 unpublished studies that have come from a global network, the RSV Global Epidemiology Network that I lead. And the members of this, many of the members of this network are in this room today. So we have 157 studies that report hospitalization and in-hospital mortality. The color shading for the different countries here on the slide is as per the 6 WHO regions they lie in. And we have the red circles that indicate the published studies and the red triangles that indicate the unpublished data. So this slide shows the global estimates of hospitalized RSV ALRI in infants, and you can't look at the mortality without looking at the hospitalizations because you derive the mortality from the hospitalizations. And what we see over here is that approximately 2 million deaths occur in children younger than 1 year of age, and that half of these are in children younger than 6 months. We also see that the hospitalization rate is related to the income region where the country is lying in. So you have very low hospitalization rates when you're looking at low-income regions, and then it goes up. And that's not surprising because we all know that access to hospital care and care-seeking behavior is very poor in low-income countries. So as I said, overall, we estimate about 2 million hospitalizations in children younger than 1 year, and half of these in children younger than 6 months. So now looking at the in-hospital case fatality ratio in infants, again stratified by income region, and also I've tried to summarize this by industrialization status, that's for developing and industrialized countries. And what you see here is that overall, the in-hospital case fatality ratio is just over 2% for the overall developing region. And it doesn't really differ by age group. In fact, if I were to show you the in-hospital case fatality ratio for children between 12 and 59 months, that would be, again, just over 2%. And that's consistent with what we're seeing in the PERCH data as well, what Kate had shown. But also interestingly, the in-hospital case fatality ratio for any given age group is highest in the low and lower middle income region. Again, it's quite likely that these kids are coming in quite late in the illness, and the quality of care may also reflect this high in-hospital case fatality ratios. But if you were to then apply these in-hospital case fatality ratios to the hospitalization estimates at the regional level that I showed you earlier, what you estimate is that about 48,000 deaths in hospital in children younger than 1 year, and 2/3 of these are in children younger than 6 months. So substantial mortality occurring in children younger than 6 months globally. And if you were to look at the overall mortality, now we don't have the pneumonia mortality estimates for children younger than 1 year at a national level, so we can't do that modeling. But for overall under 5 years, we do have a model which we've used, and that's the excess mortality model. So that excess mortality model shows about 143,000 deaths overall from RSV in children younger than 5 years. And 81% of the overall in-hospital RSV LRI mortality are occurring in infants. And 53% of the overall under 5 RSV mortality is occurring in children younger than 6 months. The excess mortality model that we use, that has some problems in itself, that if we are attributing all the excess ALRI mortality during the RSV season to RSV, so we are overestimating RSV mortality. But equally, we are excluding the role of any secondary bacterial infection that occurs subsequent to RSV, so we may be underestimating RSV mortality. I've already talked about the lack of ALRI mortality estimates for infants that preclude us from trying to do this modeling for children younger than 1 year. But if we were to apply the proportional RSV ALRI mortality for the overall under 5 children, and to look at the in-hospital and out-of-hospital mortality and consider the proportions were the same, then the overall RSV mortality in infants could be as high as 109,000. Now, for this particular estimate, we've not adjusted for influenza, primarily because we did not have data on the CFR for influenza for this particular age group. But for overall, we've done that adjustment. So just like to thank a whole lot of people who've contributed their data, and my PhD student, Ting Shi, who's in the audience, who's done all the analysis. Thank you.
So as Eric said, I based my view on the experience of 15 years of research on RSV in coastal Kenya, a low socioeconomic community, rural community, largely subsistence farming community. And on the basis of that, the answer to the question that was posed, I don't think there's very much RSV-associated mortality. So on the basis of that sort of preconception, I thought a little bit of analysis was required. So let's look at sort of a back-of-an-envelope sort of estimation. How do I point? So if we start off with a birth cohort of 100,000, let's assume that 10% of those children in the first year of life have a lower respiratory tract infection due to RSV. So that's about 10,000, so 1 in 10. Of those, around 20% of those will end up in hospital. So then we've got 2,000 left from the 100,000, that's 2 in 100. And we've heard already around about 2% case fatality rate, so we've got around 40 out of our 100,000, or 4 in 10,000. Does that sound an awful lot? Let's look at the context in Kenya. It seems to have slipped off the... Oh, thank you. Right, good. So basically, in Kenya, around about 1.5 million births each year. We therefore expect, within the first year of life, 150,000 cases of LRTI associated with RSV, with 30,000 hospitalizations due to RSV. So that's reasonably substantial, and around about 600 deaths. So I don't propose to say whether that's a large number of deaths or not that need to be prevented. But if you look at the fact that there is an infant mortality of around 36 per 1,000 in Kenya, that's around 54,000 infants dying in the first year of life from this birth cohort, and about 1% of those, therefore, might be dying due to RSV. That's based on the data that I've shown you so far. Well, it's my preconception. Now then, what's wrong with some of these estimates? Well, there might be overestimation or underestimation. And the underestimation is that if we're dealing with hospitalization, there might be a lot of death within the community. So there's an access issue. But as I understand it, the access issue becomes less and less important the more severe the disease is. So it may be less likely to be a major bias for death. But that's a matter for conjecture. Most of the hospitals where this work is done is within a research setting, and so therefore the supportive therapy, for example, oxygen support, will be greater. So you'd expect that children will have a much higher survival rate if they have RSV but need oxygen, as opposed to non-research locations where oxygen might not be available. So that we might be underestimating on the basis that these are mostly research settings where these studies are done. And as is commonly the case, and I didn't ask Kate this about the PERCH studies, that there's a proportion of individuals that present with severe or very severe pneumonia that you fail to get samples from, and it's generally those which are most severe that you fail to get the samples from. And so, of course, that potentially, if there's a significant proportion of those which are RSV positive, you're going to underestimate your case fatality rate. In terms of overestimation, well, those that die may already be very ill, and they are perhaps going to die anyway, whether or not you remove the RSV, or they have some concurrent illness that actually is the major cause of that mortality. So let's have a little look more closely at some of the data from Kenya. So over 15 years of studying the inpatient severe and very severe admissions, very severe pneumonias, in Kilifi between 2002 and 2016. Over those 15 years, 2,583 RSV cases with 65 deaths. That's around a 2.5% case fatality rate. That sort of marries up with what Harish was saying earlier. And of those, importantly, 33 of those, so around about half of them, could be protected by a maternal vaccine boosting sort of antibody in the early months of life. But around 10 cases of severe heart disease, congenital heart disease, and amongst those there are 3, 6, 7 cases that were low birth weight or premature, which you can't do very much about in a sense that those things are happening at birth. So would they die anyway if they didn't have RSV? But in terms of comorbidity, we found that actually a small proportion have bacterial pathogens, mostly Strep pneumoniae and Haemophilus influenza, but around 50% of them are severely malnourished in this population. So that's an area that is preventable. Many of these in the more recent era, of course, are not occurring because this was now we have Haemophilus vaccination and Strep pneumonia immunization. So when I said that RSV tends to be mild, if we just look at the sort of the RSV positives against the RSV negatives over those 15 years and look at various sort of key indicators of severity, we see that in general they're of a lower proportion, not always, than in the RSV negative cases. In particular, look at the levels of bacteremia, 3 to 7, and severe malnutrition, 7% to 15%. But then, what about those that you failed to sample in the first place? They are more severe anyway, and we're talking about 25% of the cases that we failed to get a sample from. And here we see much higher incidence of sort of the severe indicators, and mortality has gone from 2.5 in the RSV cases to 7 in the RSV negatives to 28% in those which are not actually tested for RSV in the first place. So is this, within this group, a large proportion of RSV positive that we're failing to measure and therefore getting an underestimate of the incidence of RSV-associated mortality? So let's just look at the trends over time. Within the population we're dealing with in coastal Kenya, total admissions has been declining, generally speaking, over that period of time. A little bit of a rise more recently. Again, malaria has risen. And this is the decline in the malaria parasite positive, and it's mirrored also by malaria cases over that period of time. With that, you've got a reduction also in bacterial cases. You have a reduction, obviously also due to vaccination of Haemophilus in the early 2000s, of strep pneumoniae in 2011. So very few cases of severe pneumonia caused by bacterial disease occurring in the more recent times. But you can see that here's the numbers of the dark bars, the black bars are RSV cases. The sort of bluish bars here are very severe RSV cases, very severe pneumonia admissions, not changing very much, but a decrease in the severe pneumonias. So what's causing the remaining very severes? Is it the remaining RSVs that are still causing that? So so you see RSV over time has not really changed a great deal, even though the overall incidence of bacteremia has changed. So these are the annual incidence of RSV in black here, in cases and for deaths here. So just concentrate on the blue backgrounds here. You can see the blue for very severe pneumonias is actually really quite independent of the severe of the RSV cases. So there's a lot of severe pneumonia, which I put down to being not a misdiagnosis, but actually probably neonatal case of sepsis, etc. So RSV doesn't seem to be the major cause of that, but actually, obviously, some during the epidemic seasons. In terms of mortality, though, we do see peaks occurring in mortality associated with very severe pneumonias. That's these blue ones here, peaking with RSV. So it's difficult to know exactly whether some of this peak is a result of RSV that we're not detecting. So at the end of the day, I still feel that RSV is probably not a major cause of mortality, but it's a little bit unclear, and so possibly more than suspected. Thank you.
Okay, thank you. I'm going to tell you a little bit of our work during the last 6 or 7 years. I think it touches Kate's work and James' work and what Eric has been talking about and the other findings in Argentina very much. Now, assessing RSV mortality is a very difficult thing, I think, and there are several reasons for that. Number one, if you look at the world entirely, right, 4% of children who died in 2008 worldwide had a medically certified cause of death. So we don't know what children are dying from. This is the first problem we have. The second problem is that, as James pointed out a minute ago, it's hard to sample patients before they die. And this is actually a study by James in JAMA a few years ago. And what you're seeing here is that often when a child is seriously ill, the drive to test for respiratory viruses is very, very low on the list. Nobody wants to do that. People are going to get blood culture perhaps to see if they can treat a bacteria. But why would you do a test for RSV? There's nothing you can do for it, particularly in regions where all the tools are not available. And in fact, if you are able to test, the materials that you have, the type of tests that you can use may be suboptimal. And so this is a study looking at the sensitivity and specificity of DFA compared to PCR. But this is the optimal situation. Typically what you'll have is different people in different shifts who may or may not have experience doing DFAs, over or underestimating RSV positivity whenever they are able to do something. And of course, it's hard to imagine that in places where you lose a lot of kids due to respiratory viruses, they will be doing PCR routinely for every patient that comes and gets admitted. The other problem is, and this is data from Mark Steinhoff and Brad, I believe, right, Eric? Yeah. So we're looking at data from Indonesia, is that many of the children who die in the world in the first years of life die at home. And we've been working on that and looking at the populations who die at home and those who die at the hospital. They are sort of different. So this is another puzzle. Who dies at home and why do they die at home? Do they die due to the same reasons that killed kids in the hospital? So one thing that we know is that to die from RSV, 99% of kids die in the developing world. You need to be in environments that are pretty poor. And this is part of pictures from where we do our work, and sometimes that is reflected too in medical record offices and other areas. And I knew people would smile, so I want to share with you pictures from other sites that are not our site. So this is the world. This is where kids die from RSV. This is not exclusive to any of our countries. So we need to understand mortality in this context. So in our region, we have 28,000 births a year and an estimated mortality rate in the sub-regions in the 20 per thousand, and a network of 12 hospitals and teams of community workers, and we have a very well-defined RSV season. So that makes it a little easier for us to work. And in that context, we looked at hospital-based mortality, and what you see in this slide is all admissions with severe LRTI. Green is RSV, which is about 65% of all admissions over 3 years. Or orange is all other pathogens, essentially, RSV negative, basically. But what you're seeing in this other slide is in green neonatal mortality, which we're separating kids that are younger than 28 days at the time they die, from postneonatal mortality, 1 to 11 months, in red, and in black, which is hard to see, I guess. You're seeing those where we confirmed that patients had an LRTI. And we captured more than 80% of these patients who died. These are all deaths. And in blue, you're seeing those where we identified RSV, which came up to 57% of those that we could test were positive for RSV. We had a few other positives for flu, MPV, one pertussis, but RSV was by far the dominating virus among those patients who died. And what we wanted to know were the risk factors for dying. Why would you die with RSV? And we conducted a hierarchical analysis, and we stratified the analysis in 3 groups. We figured that the first thing is where this child is born. I mean, what is hosting this child as the child comes into the world? And we looked at socioeconomic factors, basically. And we divided them in 3 groups. I'm not going to go through everything because we won't have time, but access to healthcare, a vulnerable mother, meaning adolescent or late childbearing, incomplete education, or a precarious home. And you see that a precarious home seems to matter in kids that have respiratory failure. So in kids that not having a ventilator would have gone on to die. But they don't seem to be very important for kids who die at the hospital. The second group are the kids who have a biological condition that makes them susceptible to disease. These would be the industrialized country risk factors. So what you see here clearly, mainly, right, is cardiac disease, neurological disease, Down syndrome. So those kids die a lot. And that is also significant when you look at mortality in the univariate analysis. But interestingly enough, if we don't follow these kids all the way to the, unfortunately, the end, clinical complications get overlooked. And clinical complications in our population were by far the most important risk factors for dying, particularly bacterial pneumonia and sepsis and pneumothoraxis. About 30% of patients who died with RSV in our population had a massive pneumothorax. And about that same number or so ended up having what was diagnosed as bacterial sepsis, mainly Staph aureus or strep pneumo. And I'm only going to show you the multivariate analysis for mortality, and you'll see there that the only remaining significant risk factors for mortality were indeed sepsis and pneumothorax. So RSV is the most frequent pathogen associated with postneonatal infant mortality in our population, and this varies by, we have pneumococcal vaccination and Hib vaccination. So in our setting, the virus was detected in 16% of all-cause hospital deaths over 3 years. 57% of LRTI deaths where tests were performed. So there were some that we couldn't test for. And as Kate showed and James showed, the CFR was lower than those in non-RSV LRTI. So its importance relied on the dominating role as an agent of LRTI. I mean, 65% of the LRTI. So even though it's not a big killer, it's very frequent. So it was mainly frequency and not specific lethality. So you can see that RSV CFR, well, James already brought it up. You can see it here in one of the studies in JAMA. This is another study where you see exactly the same thing. RSV only has a lower risk of mortality than other pathogens. So in contrast to industrialized countries, RSV in our population killed term, previously healthy infants. Deaths had a strong association with bacterial sepsis and pneumothoraxis. And the role of comorbidities, young age, and other factors was less ostensible. So to wrap it up, I would say that maybe the challenge that we face in our country, and I think many developing countries face, is turning our populations from a developing world to an industrialized country. So from sepsis and issues with medical practice that are killing our kids with RSV, to kids who will eventually die from RSV but have congenital heart disease or neurological syndromes that may be harder to protect. And you can see this in Mexico, and I'm finishing, Eric. 30% of deaths had a diagnosis of bacterial pneumonia when they died with RSV. And you can see that sometimes when RSV, and you look at RSV and mortality, they overlap nicely. Sometimes They follow each other, suggesting that bacterial infections may play a role, or RSV may have nothing to do with those deaths. And then this is numbers from the US, and you can clearly see that in the US, as I mentioned before, cardiovascular conditions, neuromuscular conditions, or congenital or genetic conditions play a major role in RSV mortality. We have another study that I'm not going to show in community mortality that Mauricio Caballero is going to be showing the last day, and we have samples from over 40 infants who died in the community, and about 25% of those had RSV. So he'll be discussing that in detail in the last day, and this is a very cool talk. So to finish, RSV mortality is a significant problem, particularly due to the overwhelming dominance of RSV as an agent of viral RTI. But I think the most important thing we see is that RSV needs a second factor. RSV doesn't seem to be very good at killing by itself. It's RSV plus. And that plus in industrialized countries may be comorbidities. And in developing countries, maybe suboptimal medical care, secondary bacterial infections, to an extent comorbidities. And in the community, other social cultural factors that challenge, complicate access to care by the families. Thank you very much.
So I'll talk about, could you present the next slide, please? Shabir's talk. So I wasn't too tough on Fernando because he organized the meeting, but also because Shabir only has 3 slides. So we'll be in good time. So Shabir, as I said, was part of, he's been doing studies for a long time, and this is data from the PERCH study. So he had 4 children who died in the PERCH study that Kate told us about, and 4 of these children that died had RSV. So I'm going to show you just 3 slides of the children who had RSV isolated. So bring up the whole issue to this discussion, the one that Tony raised, was it the comorbidities or was it RSV alone? So this is one of the children, and as Kate showed you, if you could remember her slide with all the investigations that were done, it was quite extensive. A lot of the children who had minimally invasive autopsies or MIAs were actually in South Africa. Most of them, right, Kate? Most of them were one of our PhD students did the minimally invasive autopsies. Sorry, no, I need to show you. Yeah, so this is the slide. This is the first lung. This clearly is RSV in multinucleate giant cell. Very nice. The next slide, you can see all the staining that was done. And here, RSV, let's go back. RSV was done. So maybe he sent some other slides. But RSV was done, and the right and left lung culture, there was no growth. But what you see here is actually CMV. Now, where is the CMV? That's it. So there was CMV in the second one, despite the fact that RSV was isolated in the lung. And molecular testing, all of the 4 subjects had RSV cultured from the lung. So it was not just pure RSV. They had RSV with CMV and with pneumocystis. So the 3 of the 4 deaths that he had causes other than RSV. And if the MIAs had not been done, we would not have identified them as any other cause. So CMV, PCP, and other viruses. So I'll stop that part of the presentation. I wish Shabir were here to present the data, but that's really what he wanted to present, that in South Africa, where they've done minimally, even though you have good pathology and staining, it's not quite as simple as isolating RSV from the nose and saying that that is the cause of death. Now, Fernando has also shown some of the same data, and though his rates of co-infection are less than what we found. And I'll stop here, and I'll just give you a summary of what we've been discussing and some questions that come from these presentations, starting with Keith's presentation and going through all the presentations in the session, as well as the last 3 session. So I'm going to show these slides to stimulate discussion, and that's what, and you please feel free after this. We have 20 minutes to discuss as we wish. So the first thing that we are learning from Kenya, from Harish's data, is that really ALRI mortality is going down, regardless of all of the things that are happening besides what we have. So the estimates of ALRI mortality and general childhood mortality, neonatal mortality, a little less so, but they're all really going down from 1970 to 2010. And this is also true between the 1 to 4-year-olds. So if you look at this data from published in The Lancet, so despite all our changes, there's been dramatic changes in case fatality and ARI mortality over the last 20 years. So the questions that have come up from all of this, despite all our treatments and so on, I think they've estimated that 50% of the reduction in this mortality is because of non-medical social reasons. So that is where we're at the moment, and we've got to face these questions. So we do need to get more accurate estimates, and we haven't gone through, Harish wasn't given a chance to go through his whole presentation, but these are some of these issues, and the issue that James raised and Harish acknowledged, that our samples obtained from those who die early, that is sample collection, and that is what Fernando was also mentioning. So throughout the theme was, for hospital-based case fatality rates, is collecting specimens from those who die early the ones most likely to survive. Now, there are complicated analysis that we tried to do for this manuscript, and Kate was instrumental in helping us think through some of those issues as to, can this be done? In the end, we decided not to include it in the analysis, but this is an important issue, right? The one that all of us brought up. Does estimating the mortality of under-ones underestimate the overall mortality, since most mortality occurs in the first 3 to 6 months of life? So Harish has now been able to differentiate, to at least make estimates for the first 6 months as opposed to the second 6 months. And the earlier estimates that you saw from 2010 actually just had 0 to 1 year. Now, it would be nice for studies to actually present data on a monthly basis, because we still can't make an estimate for the 0 to 3 months, perhaps the one that is most affected by maternal immunization or potential monoclonal antibodies. Does data from tertiary centers really reflect what happens in district hospitals? So you saw the data that Harish presented in low-income countries. Only 7% of the overall hospitalizations come from there, even though they contribute to a high mortality, indicating that, as James was also saying, the care-seeking behavior may influence what happens. So we're getting most of our data from tertiary care centers, not from rural centers, not from hospitals where a lot of the subjects do actually go to. So are we biasing the data in that direction? Community case studies, does the excess mortality method overestimate the burden? And it's been widely used in flu. I see Arnold Monto was in the crowd. But does it overestimate for RSV? Can we get more accurate estimates as being done at the moment? So the Gates Foundation is funding some studies to look at Fernando's study that you just heard about. There's studies in India, Pakistan, and potentially Zambia that are going to look at children who die to get direct estimates of mortality from children who die. And what about the relative role of comorbidities? So in South Africa, it was quite clear that of the 4 children, 3 of them had comorbidities. In Argentina, you saw some data from the hospitals, and you saw even Fernando's data that comorbidities may be important in the hospital. So will preventing RSV prevent these deaths? So is it possible that preventing RSV in those with congenital heart disease actually prevent mortality in those subjects? Now that there's a new definition, so this is it's a bit of an issue. So we are stuck with WHO definitions for severe pneumonia. In the old days, it was lower chest volume drawing identifies severe pneumonia. Now there's a treatment algorithm with WHO whereby this is not considered severe pneumonia anymore. So previously, children who had chest volume drawing were referred to the hospital and were hospitalized. At the moment, they're being treated at home. So this may seem abstruse, but in the end, what's going to happen is, will this decrease the burden of respiratory illness? So all the burden estimates that we're making, 33 million hospitalizations, if we now start collecting data, will the rates of hospitalization for ARI go down? And conversely, will that be translated into mortality occurring at home? So that's the issue that is still not clear, and that's why it's important to conduct community mortality studies. And I'll stop here, and there are several other questions, but we'll take time now for the questions. Please ask questions to the panel, and we'll be happy to take this discussion as it goes. Tony.
Thank you to all the speakers. One of my concerns has been, I think, by using hospital-based case fatality rates, we're missing a large population of children that might be dying at home or in the emergency room who may not be evaluated. And I say this, if I use flu as an example in the United States, 40% of children that die from flu die within the first 2 days, and they oftentimes do not make it to the hospital or not hospitalized. And the majority of those that die in that manner are healthy. They don't have comorbidities. And so I wonder whether using hospital-based data, we're skewing our view of maybe a more comorbid population versus trying to do community-based studies. And so I ask this to y'all.
So I did not show our community-based data because we will be sharing it on Saturday. But I'll tell you something about this study, though. We have community-based data in this study, and it's interesting because when you look at the distribution of hospitalizations or severe RSV-LRTI, you see the typical low first month and then a peak that slowly fades into the second year of life. When you look at severe disease, that starts, really severe disease. I mean, kids that need mechanical ventilation, that is less well preserved. But when you look at mortality, the distribution is a lot more random. You don't see the typical distribution that we see with hospitalization. So when we went to the community had, I don't know if I'm clear, but what I'm saying is mortality doesn't seem to follow the pattern of hospitalizations. You don't have the same type of drawing, the kinetics of the patients who die when you look by month, as you have when you look at the patients that get hospitalized. Now, that said, when you look at the community and you look at deaths in the community without causal attribution, so this was our first study, what you see is that there's a clear peak in our region in winter, just parallels very nicely the peak that we see at the hospital. But when you take those patients and look at their age distribution, it parallels hospitalizations. It doesn't parallel deaths at the hospital. So deaths at the hospital seem to be sort of an unlucky event. They came across Staph aureus or strep pneumo, or they had a massive pneumothorax or something else. But the community deaths who occurred in healthy children who seemed to be normal weight and maybe had 200 grams lower than controls in our subsequent studies. So not significantly different than healthy children. Just follow the pattern of patients that got hospitalized, suggesting to me that these patients should have gone to the hospital but never made it to the hospital. So they tired to death. They didn't die of a secondary bacterial infection. They didn't blow a pneumo at home. They just died because they may have had a family with 5 or 6 children. They were not able to make it on time, and they just were quiet. So I think we're facing two very different populations, and we need to study them separately to understand the whole spectrum.
So
James.
I think you're absolutely right, Tony, and hospitalization as a place to look for mortality is flawed, but obviously it's convenient, and that's why it's been used in the past. But we won't know the answer to that until studies are actually undertaken in the community where you have, for example, minimally invasive autopsies of children, which of course has huge challenges associated with it, but I believe that's what's happening with the CHAMPS studies that are going to look at the at mortality in the community.
Ross.
Ross Smith, University College London. So, Harish, a great presentation, and I wanted to ask you why I think you showed that hospitalizations and mortality was actually lower in low-income countries compared to low middle-income countries. So is that real, or is it apparent, or can it be explained by the subsequent two speakers in that these kids are dying in the community, out in villages before they get anywhere near hospitals? You will be familiar with the studies that you've drawn from.
Yeah, so a very important question. And I think I tried to point out that the low hospitalization rates for RSV in low-income countries were actually an artifact because of these kids are not getting hospitalized because of poor access to care or poor health-seeking behavior. And because our in-hospital mortality estimates are based on applying the hospitalization rates to the in-hospital case fatality ratios, which are higher in the low-income settings. Our overall numbers for kids who die in hospital from RSV are lower. But that's what you would expect if you're not, if you're having RSV or you're sick and you're not being taken to the hospital. Which is why we know that for pneumonia, 80% of the mortality occurs outside the hospital. We published that as a global analysis that was done a few years back. And we tried to sort of replicate that for RSV. And for RSV, it seems that about 56% of the deaths are occurring outside the hospital. So not as much as 80% as you would see for all-cause pneumonia, but still a substantial number are occurring outside the hospital.
Kate.
So really interesting discussion. Fernando, I have a question for you about, I just wanted clarification of something I think you said, which was that 56% or 57% of the LRTI deaths are RSV test positive.
So the majority of LRTI associated deaths in that study, were tested for RSV, about 80%. And you're talking within the RSV season. When you look at the other, you don't really have a pattern that you can track outside the season. It seems to be like a peak and valley situation in our environment, but we were only there between May and September during that time. And when you test those patients, about 80%, about 57% had RSV. Then you had some that had flu, but I mean, there were a couple, like 2 with flu and 1 with human metapneumovirus, 1 had pertussis. So RSV was by far the most common pathogen.
Right, so I just wanted to contrast that with the observations across the 7 countries in PERCH where less than 10% of the deaths were RSV test positive. And I wonder if you could just, what your interpretation of that would be. To me, what it means is that as you go to a higher access to care setting, and as there are improvements in care, improvements in socioeconomic status, the things that children die from are, as a proportion, going to more dominantly reflect the viral pathogens and less so the bacterial pathogens.
I agree.
So is that your interpretation also? And should we be careful, especially when we're using proportions, as if that reflects burden? Because
RSV was 16,
proportionality is always going to go up when you reduce the causes from other things.
Yeah, I absolutely agree. I think the overall mortality in that study over the 3 years, RSV represented 16% of, I mean, at least RSV was isolated in 16% of the deaths. But that's what I was trying to say too. As we move from, I mean, this is a long journey. I don't think we're going to do it today, but as we move from a developing country situation like we were looking at to an industrialized country like the US data where people are dying and have congenital heart disease or, Down syndrome, and those are the only kids who seem to die from RSV. Probably that's the transition where RSV may reflect a higher proportion within the deaths that are attributable to pneumonia and stuff like that, because the other causes are starting to fade. We don't see a lot of pneumococcal deaths, at least alone, right? Yeah.
Keith, before you go on, let me just ask James a question based on what Kate just said. So, you showed very nice data over the last 15 years of RSV and severe, non-severe pneumonia. We know that in 2011, February, Kenya introduced pneumococcal vaccine. Subsequent to that, Kalifi, you've been doing a study, right, for the last so many years, and you don't have any invasive IPD except for like one case last year. Is that correct?
There's very little
Yeah.
invasive
It's almost gone away.
bacterial disease, yes.
So, was it my perception that there was very little impact on severe and very severe pneumonia that was being hospitalized? You would expect that if pneumococcus was a major cause, then it would have an impact. And you could also study the impact on RSV hospitalization, answering potentially Keith's question of does pneumococcal vaccine influence RSV hospitalizations?
Okay, what I presented there, I think I could have presented better because we included what was potentially a lot of perinatal mortality and perinatal disease there. So I should have excluded sort of the first month of life, perhaps, or the first few days of life, where, in particular, the first few days of life, where it's not going to be RSV that's the cause of it. So I think those pictures were slightly biased by including perinatal and neonatal mortality, which won't have been much affected by the vaccination from strep pneumonia and Haemophilus influenza.
So she's telling me we have just a few minutes left. We'll take this discussion for coffee. Keith and then Kim.
So my bias, Jay, looking at your data, was that there did seem to be an impact post-2009 with reduced hospitalization, but you can look at it and tell us if it's really there. So the key here is what kills kids with RSV. And we know that the major drivers of mortality are malnutrition and hypoxia. And so it didn't surprise me where even in Argentina, malnutrition came out as a driver of a mortality. What we know from all of these studies is that if you get to a tertiary hospital with oxygen, you're not going to die of RSV. Well, you may, 2%, but that have underlying comorbidity. So the big question then, as others have pointed out, is what's going on in the community. So we at the Foundation are now funding studies in the community, and the key, I think, is the high ratio between RSV in cases versus controls. So if you find a kid who dies in the community and they're RSV positive, we can't attribute absolutely, but we could be at least 90% sure that RSV contributed to that mortality. So the hope is that without having to do autopsies in the community, rather simple studies in the community looking at nasopharyngeal swabs from kids who've died could tell us the RSV burden, and I know that's going on here. We're funding a study in India to do that, and we're studying other studies, Pakistan and elsewhere. And then the question, it seems incredible to me that we don't have more studies along the lines of what Fernando talked about, which is simply an observation of the seasonality of mortality in the community in kids in developing countries. And if there really are compelling data that there's a spike in mortality associated with the peak of RSV season, be it once or twice a year, that certainly would also be something I think worth investigating.
Yeah. Keith, if I may ask Harish because Harish has been looking at the seasonality and mortality.
So I think whatever data we've seen up until now from all the sites that have contributed, what we see is that clearly the pneumonia mortality peak is immediately after the RSV season in most of the sites. Now that could be because either it could be the pneumococcal mortality itself, or in many of the sites, the flu season immediately follows the RSV season. So it's very difficult to sort of tease out and say it is RSV itself, but you do see a spike in mortality immediately after RSV, within 3 to 4 weeks of RSV.
Yeah, and that lag is well known. So it's that interaction, I think. Kim, a last...
Yes, Kim Mulholland from Australia. Thank you. I just want to emphasise the point that Eric made before about the changing WHO recommendations for hospitalisation, and I guess put a caution out there about interpreting too much trends in hospitalisation rates, which I think is very difficult. I also wanted to go back to the first presentation from Argentina on mortality data. with the sort of discussion that came from a question about the role of nosocomial infections. In Vietnam, roughly 10 to 20%, depending on which site you're in, of all children are hospitalised in the first year of life, most of them with respiratory infections. Most of them are actually hospitalised with fairly mild respiratory infections, but that doesn't stop them getting antibiotics and drips and things. And the duration of hospitalisation can be 7 to 10 days, depending again on the hospital. So you've got there the most. These are extremely crowded conditions. You have an extraordinary situation for nosocomial infections. And whilst the RSV may be associated with deaths in those children, I do concur with the idea that a really significant number of them might actually be nosocomial infections as a result of inappropriate hospitalisation. This is the problem that's common throughout Asia, actually.
Thanks for drawing our attention to that, Kim. It's an important point. Karen Hall actually first published the whole importance of nosocomial RSV in the New England Journal and showed that the mortality, even in the US in those days, was much higher in children who had acquired RSV nosocomial. So it is an issue, and certainly in India with AMR, this is a very critical issue. So thanks for pointing that out. It's now time for coffee, so we have to stop the discussion, as interesting as it may be, but how long for coffee?
I think we have about 15 minutes.
15 minutes for coffee, and then please come back here. Thank you, everyone.